1.
Muy bien. Buenas tardes a todas, a todos. En nombre de la Comisión Directiva de la Sociedad Argentina de Inmunología, les damos la bienvenida a esta serie de webinars que hemos programado, que hemos dado de llamar Jueves de Inmunología Clínica. En esta ocasión nos acompaña el doctor Michail Lionakis, a quien tengo el gusto y el agrado de presentar, y que nos acompañan Laura Chiapello, que es experta en enfermedades fúngicas del Centro de Investigación en Bioquímica Clínica e Inmunología de Córdoba, y la doctora Silvia Danielean, que es jefa del Servicio de Diagnóstico Molecular del Servicio de Inmunología y Reumatología del Hospital Garraham, y están aquí con nosotros y van a ser de coordinadoras de este webinar. I would like to thank Dr. Michail Lionakis for his kind participation in these webinars. It's really an honor for our society to have you here with us today. And well, I will give the word now to Laura and Silvia, who will introduce you, and then we can start with the talk. Thank you again for your participation. Laura, Silvia, les doy la palabra.
Gracias, Mariana. Bueno, para mí es un gran placer presentar al doctor Michail Lionakis, quien es médico e investigador científico, experto en enfermedades infecciosas e inmunología. Realizó sus estudios de medicina y doctorado en ciencias en Grecia, en la Universidad de Creta. En 2002 se muda y establece en los Estados Unidos con una beca de investigación en el Centro de Cáncer Anderson de la Universidad de Texas, bajo la dirección del doctor Dimitrios Kantoyanis. Allí se formó en el diagnóstico y manejo de enfermedades fúngicas oportunistas en pacientes con cáncer, y también en investigación básica, trabajando en modelos experimentales de aspergilosis, fusariosis y candidiasis invasiva. En 2008 se unió a los Institutos de Salud de Estados Unidos, el NIH, en los laboratorios de inmunología molecular del Instituto Nacional de Alergia y Enfermedades Infecciosas. Es allí donde en 2012 establece su propio laboratorio y la unidad de patogénesis fúngica, donde actualmente es el jefe de esta sección dentro del Laboratorio de Inmunología Clínica y Microbiología. El doctor Lionakis a lo largo de su carrera ha recibido numerosos premios y distinciones. Ha publicado más de 150 artículos científicos en journals muy prestigiosos, tales como Lancet, Journal of Clinical Investigation, Nature Immunology, Science, entre otros. En esta oportunidad nos pareció interesante invitar al doctor Lionakis a este webinar de inmunología clínica, ya que tiene una enorme experiencia en el manejo de pacientes con el síndrome de APECED. Estudiando justamente a estos pacientes, recientemente su equipo ha publicado en Science un artículo donde describe mecanismos nuevos de susceptibilidad a las infecciones fúngicas en las mucosas. Sus hallazgos no solamente tienen implicancia en el tratamiento de estos pacientes con el síndrome APECED, sino que además abren el camino al estudio de la inmunidad específica de tejidos en otras enfermedades. Thank you, Michail, so much for accepting our invitation and share your knowledge with our society. It is a real pleasure to have you with us today. You can start and share your screen whenever you're ready.
Well, I would like to thank you all for the kind invitation. I hope you can see my screen and hear me well. And thank you very much for your very kind introduction. I actually can understand Spanish, so I think I got everything you said, and it was all very kind and accurate. So what I will try to do over the next 45-50 minutes is to try to give an overview with regards to this syndrome called APECED, as you mentioned, caused by air deficiency, where over the last 8 years, we've had the privilege to see close to 150 such patients here at the National Institutes of Health. As Laura mentioned, I'm actually an infectious disease and immunology trained physician scientist, and before going into APECED, just as an introduction of how we study fungi in the lab, we try to understand the mechanisms by which we all defend on a daily basis against these two very important fungal pathogens that in this country, in the United States, cause over 25,000 deaths a year in immunocompromised patients, despite medical therapy. So the way we've decided to do this is being at the NIH to take advantage of this intramural environment and bring a lot of patients who have inherited disorders in which these fungi are critically important pathogens. At the same time, we've worked to understand novel iatrogenic risk factors as new biologics are coming into the clinic, or where how we, in an acquired manner as physicians, put patients at risk while we try to help them for their other diseases. So in addition to these clinical studies, we do a lot of work in clinically relevant mouse models of infection. And our goal really is to try to understand the mechanisms by which we defend against these pathogens, and ideally try to help patients if possible. So today I'm going to, from a fungal end, I'm going to mainly focus about Candida and talk about one disease called APECED, but I'm going to talk predominantly about the syndrome in general, and at the end focus on Candida, not exclusively talk about Candida. So APECED stands for autoimmune polyendocrinopathy candidiasis ectodermal dystrophy. It's also known as APS1 or autoimmune polyglandular syndrome type 1. It's actually a rare recessive syndrome caused by mutations in the AIR gene. And what got my interest about 12, 13 years ago is that this is a multi-organ autoimmune disease that it's a devastating autoimmune disease, as I'll show you in a minute. And these patients get a signature infectious disease, chronic mucocutaneous candidiasis, or CMC. Actually, from our Nordic European colleagues, this disease was initially reported as predominantly carrying endocrine manifestations, which is absolutely accurate, they do. And actually, this classic triad of candidiasis, hypoparathyroidism, and Addison's disease, having 2 out of these 3 manifestations is sufficient to give the clinical diagnosis. And you will all agree, as opposed to many other immunological diseases or dysregulatory diseases, this is a very characteristic triad. So having 2 out of these 3 almost conclusively makes the diagnosis. Now, what we've done over the last few years, and I'll show you some examples of that, is through a comprehensive prospective follow-up of all of these patients, we have to realize that they're, in addition to the endocrinopathies, they get a lot of other immunological diseases, some of which have dire consequences if not diagnosed early and treated. And I'll highlight a couple of those. Now, what do we know about AIR and APECED? So AIR is a very important transcriptional regulator in the thymus, where in these specialized epithelial cells called medullary thymic epithelial cells, it's critical to promote the expression of peripheral self-antigens and the negative selection of self-reactive T cells. So in the absence of AIR, self-reactive T cells escape in the periphery and have been shown in mice to be both sufficient and necessary to cause tissue injury. These patients also have a broad array of autoantibodies against cytokines and tissue-specific antigens. And you'll hear, I think, in a week or two from Dr. Casanova, or how maybe type 1 interferon autoantibodies might contribute to severe COVID. I'm not going to elaborate on that today. In mice for the tissue autoimmunity, because the mice don't have autoantibodies against cytokines, those have not been shown directly to be pathogenic in mice for the tissue-specific autoantibodies. So this is where we work. This is the NIH Clinical Center. This is the 300-bed research hospital that enables us, with our labs being in close proximity, a permissive environment really to do bench-to-bedside investigations. And when I started being interested in this disease, we assembled a trans-NIH multidisciplinary team of physicians, scientists, and scientists. You might recognize Sergio Rosenzweig here, who is from Argentina and now here at NIH, a dear colleague, spanning 10 different NIH institutes and a lot of specialties, so that we can understand all facets of APECED. So when the patients come here, they are seen by those specialists, and this is my team at the clinical level and at the bench level studying APECED. Elise, Monica, and Tom at the clinical level, and then Greg, Yanis, and Vas at the bench. So what we do with all of the patients is we take a very uniform approach. All of the patients are evaluated in a uniform manner from all of the specialists that are listed here. They all undergo whole exome or genome sequencing and undergo a very uniform evaluation, clinical for sure, and research at the same time, with imaging and endoscopies when needed clinically, but also for research purposes, as I'll show you in just a minute. So we've had a surprisingly rapidly growing cohort. When we started, we didn't think that we would have close to 150 patients in less than 8 years enrolled. And we keep getting refers. These are not only from the United States. I would say probably 30 patients now have come from all over the globe, from Argentina included, from Europe, even from Australia. We're more than happy to evaluate any patient who wants to come and see us. So what I'll try to do over the next minutes is to try to highlight 3 different aspects, how we've come to realize that APECED has expanded clinical features that can actually make an important contribution to making an early diagnosis. Talk a little bit about autoimmune lung disease, which is a previously not very well recognized entity that actually has significant morbidity and mortality if left untreated. And then end with some recent work that Laura indicated about a potential novel mechanism by which candidiasis might happen in these patients, and maybe more broadly as well. So what we very early on realized as we were prospectively evaluating these patients in this very comprehensive manner is that there was a significant enrichment of non-endocrine diseases and a delay in developing of the diagnostic criteria. So when we look at the number of patients who have, these are number of endocrinopathies, patients typically have 2 to 3, with hypoparathyroidism and Addison's being the more common. This is well known. But as you can see here, a lot of non-endocrine manifestations per patient. These patients get over 30 different disease manifestations, of which 25 are non-endocrine in nature. And it's important as immunologists, which this audience is, to really recognize those, because they do have an important role to play into the disease, and treatments might actually be relevant. So what I have highlighted here is a hexad of intestinal enteropathy, hepatitis, gastritis, autoimmune pneumonitis, a very characteristic rash I'll spend a minute on, and Sjogren's that can happen in 40 to 80% of the patients. These are much enriched than European cohorts had described in the past, and also a lot of manifestations that hadn't really reached a lot of attention in the literature before. So what do I mean by delaying developing diagnostic criteria? This has been also highlighted in previous studies, but what we wondered as we were seeing the patients, these criteria are extremely solid. However, do they really help every individual patient when they're a child and they go from pediatrician to pediatrician with new manifestations to make an early diagnosis? And what you can see here is that the mean age of making a diagnostic diet was about 7.5 to 8 years in this first cohort that we reported, but only 1 out of 5 patients had their first 2 manifestations about these very classic characteristic manifestations. And instead, 4 out of 5 patients would develop non-triad manifestations before developing a diagnostic diet. Those manifestations would not necessarily alert clinicians that this could be APECED, resulting in a delay in diagnosis. So what are those manifestations? First, one very characteristic early manifestation that we've seen in almost 65% of the patients now is an urticarial eruption, and I'm calling it urticarial eruption and not urticaria because it is really a very characteristic rash that happens with CMC as the 2 first manifestations. And it looks like this, and very characteristically, it's a neutrophilic dermatosis. These are neutrophils with MPO when you get biopsies. This happens the first year and a half of life. And you can see some patients have paniculitis from that. And again, you do have T cells, but also a very characteristic myeloid invasion. Now, besides this, what we've now been able to do is start recognizing patients who might have candida and these APECED rash, as we now call it, very early in life. So this is a 10-month-old. This is the youngest patient that we've been able to diagnose through this, greater awareness. That gives us hope that maybe in the future we'll be able to identify patients very early, as I'll allude to it in a minute, to maybe intervene before they develop the devastating disease manifestations that follow. So when we look broadly and in an unbiased manner of what other disease manifestations can happen early, we identified this, what we call a giant triad of this APECED rash, intestinal malabsorption, and enamel hyperplasia that happen similarly early and in high frequencies like the classic triad manifestations, and proposed that perhaps if we put the classic and the adjunct triad manifestations together in expanded diagnostic criteria, this could lead to earlier diagnosis. And in this first data set that is now confirmed in over 100 patients in follow-up studies that have not yet been published, in both actually American patients, both North and South American patients, but also a cohort of European patients from non-Nordic European countries, is that you can actually make a diagnosis about 4 or 5 years earlier, so about half from what the diagnosis would be just with diagnostic classic criteria. And importantly, about 50% of the patients could have potentially be diagnosed before developing life-threatening Addisonian crisis or hypocalcemic seizures, should that expanded HEXAD was part of the diagnostic triad, expanded criteria. So the bottom line from this first segment is that the clinical spectrum of APECED can be broader than previously appreciated. We don't fully understand yet the differences between some of the European and the American cohorts. It might be genetic or other modifiers. It might be some of these manifestations go unnoticed unless you really focus and do this very comprehensive prospective evaluation. But I think the bottom line is that affected children in the Americas, US and Latin America, are likely to be evaluated before they go to an endocrinologist with the classic manifestations by a lot of other specialists, dermatologists, allergists, dentists, GI specialists, hepatologists. And it's important that they're aware of that, because that could lead to early recognition, prevention of life-threatening endocrinopathies from a crisis standpoint, and perhaps in the future where we want to go, early implementation of immunomodulatory therapy, as I'll show you in the second segment, where we can use now treatment. We want to implement prophylactic, if you will, or immunomodulatory preventive approaches to abort the development of this devastating disease. In the second segment, I'm going to spend a few minutes talking about lung disease. And when we started, not much really was very evident in the literature. There were case reports of lung disease. There were a couple of important papers by the groups that are listed here on the right lower corner, describing that there could be lung autoimmunity in this disease, featuring bronchiectasis. There were 2 lung-targeted autoantibodies that they had been shown to correlate with the presence of pneumonitis. Mark Anderson's group showed that actually if you make a CD4 T cell specific for one of those and you adoptively transfer them in mice, that's actually sufficient to cause the disease. That actually can be lethal, and it was very unclear on how to treat. So we got very interested in this because very early on in the first year of evaluating some of our patients, we had a couple of patients that I'll show you some representative imaging studies that had profoundly severe disease, and both patients unfortunately died because of pulmonary autoimmunity eventually. So in the same spirit of a uniform evaluation prospectively, where everybody would get a chest CT, everybody would get standard questionnaires, we would measure the autoantibodies, but also when they had respiratory symptoms or pulmonary imaging abnormalities, they will undergo a very comprehensive pulmonary evaluation. We were surprised to find that almost 4 out of 10 patients actually have autoimmune pneumonitis. And I'll show you what I mean by that term in a little bit. These patients had chronic symptoms attributed typically to reactive airway disease, asthma, or allergic bronchitis. It's important to note that this is really not what the etiology is in the majority of the patients, not to mention, of course, that some patients might not have asthma, but you'll see here as I go through some of these examples what I mean. So now that we've evaluated all of these patients, and we've caught patients in different stages of the progression, we think that this initially presents with an interstitial lung disease. So this is one of the patients that came to us. This is an SCT we retrieved in retrospect with a diagnosis of asthma, actually. And you will all agree that this is not how asthma would look like. This is, what a PCP, PJP pneumonia would look like. This early interstitial disease progresses in patients. And this is another patient that came to us with a diagnosis of asthma. And when untreated lung inflammation occurs for prolonged periods of time, I think you all know that you can then start getting into scarring problems in the lungs that manifest with bronchiectatic lung disease, which is a problem because it represents a structural lung disease where you get colonization of pathogens, you start getting early PFT abnormalities. So here are a few examples of bronchiectatic lung disease in people who didn't know that they had autoimmune pneumonitis. This is another patient of ours that developed this in her 30s, actually, so more late than many other patients. And then when unabated inflammation continues, patients can get very severe bronchiectasis when you start seeing what you typically see in patients who have CF or non-CF bronchiectatic lung disease, that is recurrent infections, whether these are from bacteria or mycobacteria, or you get severe PFT abnormalities. And I would say in our cohort, almost 20% of patients with pneumonitis are actually on home oxygen. So this can result in severe hypoxemia. This is one of the patients that we saw in the very beginning. This at the time was a 14-year-old boy who came to us just 3-4 months before he unfortunately died. He had most of his lung replaced with bronchiectatic lungs in those 2 cuts. He started having cough at the age of 9 and died 5 years later from unabated autoimmune lung disease. This is another patient of ours who came to us with 40 years of history of cough attributed to allergic and reactive airway disease. The aftermath of unabated inflammation with bronchiectasis that then led to secondary pulmonary MAC. These are MAC cavities, one of which ended up getting a bronchopulmonary fistula here. This patient spent 1.5 years in our hospital, underwent right lower and middle lobectomies, actually was able to leave the hospital. I'll show you how we treated him. But unfortunately, after a few years of remission, he developed a bacteremic gram-negative sepsis starting from a lung infection and succumbed to it. So this patient went from cough onset at the age of 7 to this at the age of late 40s. So the first patient in 5 years. So progression varies significantly. And what we now do in every patient is a chest CT, because many patients early on have asymptomatic ground glass opacities, and I'll show you some examples. And because in all of these patients that we have now proven with biopsy that they have pneumonitis, the autoantibodies are present and specific, but not very sensitive. So just a negative autoantibody will not necessarily rule out the presence of pneumonitis. This also indicates that there are other lung-targeted self-antigens that we do not know yet about, and that's an area where we're very keen in identifying potential other autoantigens that there is autoimmunity targeted by T cells. So now that we knew that this is a problem, we still do not know how to treat the patients. And in order to be able to understand that, we wanted first to understand what's the immunopathogenesis of the problem. So in order to do that, we went and did bronchoscopies with lavage and biopsies in consecutive patients, as well as healthy volunteers that we enrolled in our research protocols. And then we did corroborating studies in mice. And what we came across was a very characteristic compartmentalized immunopathology that has a very high diagnostic utility, as I'll outline over the next 5 minutes. So what you see in the airways in the absence of infection is a predominance of neutrophils that are very activated because they express surrogate markers of activation here as B558, the extracellular domain of NADPH oxidase, or the granular content CD66B. There are others that we've shown, and I'm not showing you here for the interest of time. And as a result of that, in the BAL, you get byproducts of neutrophil activation, including NMP9, that has been well recognized to potentially contribute in bronchiectasis in CF and non-CF patients. And consistent with that, we see a high amount of LDH in these patients' airways, implicating tentatively the excessive neutrophils for long term into the potential pathogenesis of lung disease and airway disease. In mice, we also saw the same. Again, these are unmanipulated, uninfected mice that had a neutrophilic accumulation in their airways. Now, in the tissue, the story is very different. When we started doing biopsies, and endobronchial biopsies now what we favor as the gold standard to make this diagnosis because it's less invasive than transbronchial and can give us the information we need. You see this marked thickening of the basal membrane, and then you see these marked intraepithelial and submucosal infiltration by T cells more than B cells. And this can be both CD4s and 8s, and actually the 8s are more intraepithelially and the 4 are more submucosally. Now, when you go deeper in the tissue and you biopsy the bronchioles, you see the hallmark of what this disease is. It's bronchiolitis and peribronchiolitis. Some patients get fibrosis and muscular hyperplasia. Here, the histological picture is similar, but somehow different also. So here is a bigger magnification of a bronchiole with a lot of T cells. Again, CD4 surrounding and CD8s also infiltrating the epithelium. But here, B cells make lymphoid aggregates, as you see in lymph nodes, and that shouldn't be here in the lung. This is, again, the bronchiole. You see B cell infiltration around, but you see lymphoid aggregates in the deeper tissue. We went to mice and showed the same. So, and if you look at knockout mice, they have the same peribronchial and deep-seated kind of lymphoid aggregates that stain for CD3 and 20 as in humans. The mouse corroborating pathology gave us the opportunity to ask, is it the B cells, the T cells, or both that drive the disease? And can we devise a potential therapeutic strategy? So in order to answer this question, we made air TCR double knockout mice, that is mice that lack air knockout mice that lack T cells, or AR IgHM double knockout mice that air knockout but don't have mature B cells. And what you can see here is a complete reverse of all of the phenotype in the mice that don't have T cells. This is shown before, that the syndrome in APECED, consistent with this being a T cell, self-reactive T cell escape problem. If you eliminate those self-reactive T cells, you don't get autoimmunity. There's a contribution of B cells, as you can see here, partial, but nonetheless less so than the T cells, but better than the air knockout. This gave us a potential hint of targeting lymphocytes. We thought initially about doing Campath to eliminate T cells, but this comes with infectious complications. So we decided to do Immuran in patients because a lot of them had been on treatment with that for hepatitis. So we knew that it is not toxic in them and it's well tolerated. And add rituximab in order to capitalize on the B cell component as shown in the mice. So when we did that, and I'm going to show you here the data on the first 5 patients that we consecutively treated, we've now treated another half a dozen of patients and the data are alike. There was resolution of their symptoms. Those patients who were actually on the very late bronchiectatic phase and they would get infections, stopped having infections, they had a much improved quality of life. And when we looked at radiographic findings in a blinded manner by 2 different radiologists, what you would see is a dramatic decline in residual radiographic abnormalities. And here, 4 patients as an example. This is an 8-year-old at the time who had this impressive disease. A month later, almost complete resolution. And 6 months later, the same. These are coronal views that just highlight the extent of the disease and the normalization. And these are 3 other patients. This is actually a patient who had extensive ground glass opacities and early bronchiectasis without having symptoms. And this is again within a month, and again 6 months later, the same. And this is the patient that I mentioned to you that had the right middle and lower lobectomies. We were very nervous early on to put him on immunotherapy, immunomodulation, because he still had MAC. But as you can see here, within 6 months of being on azathioprine and rituximab, his underlying autoimmune pneumonitis resolved. He did not have a recurrence of MAC. And this is another patient where you could do these fancy 3D reconstructions and show that most of the disease is alleviated. That comes also with pulmonary function improvement. They desaturate on the 6-minute walk before treatment, and they don't after. They walk longer, their FEV1s improve, and the DLCOs also improve. Now, in rare diseases, sometimes, and I would pose that it's more common than we think, we can find potential pathogenetic mechanisms that might actually apply to more common diseases. So in this particular case, we focused on two diseases that are still uncommon, but more common than air deficiency, that have secondary air deficiency. This is patients with thymoma and RAG deficiency, the hypomorphic RAGs that cause autoimmunity. These patients were reported to have a not very well characterized autoimmune lung disease. Turns out that there are many features that are similar. So you can see here a couple of examples of pulmonary autoimmunity in these patients. And when we focus on thymoma patients, where we have a large cohort of these followed here at NIH, their intraepithelial and submucosal endobronchial biopsies look like an APECED pneumonitis. This is deeper tissue with the peribronchial and B-cell aggregates. That has led us now treat 2 patients with the same regimen of azathioprine and rituximab. And this is now before and after. So that has given us a window into a different disease where the neutrophil predominance in the airways and the compartmentalized lymphocyte infiltration deeper in the tissue, it appears to be similar with APECED. We're now looking at Sjogren syndrome, because Sjogren's patients, in about 10% of the time, they develop an autoimmune bronchiolitis that has not been very well characterized, and it has the same features of neutrophilic airway expansion and peribronchial inflammation. There's a large cohort of Sjogren's patients followed here at NIH, and we hopefully after the pandemic will be able to develop a trial to actually treat them with this, because there are about 3-4 million patients with Sjogren's in this country, therefore far more common than APECED, and perhaps a common mechanism of how autoimmunity happens in their lungs. So we're not going to go through, obviously, all of our investigations. I'm listing them here very briefly. I'll focus on for the last 20 minutes max on Canada and show you some recent exciting data that we've got. But these patients get a very severe GI disease that is not well characterized. Some of them get purate cell aplasia that is refractory to all treatments. We're, as I mentioned, very keen on prophylactic immunomodulation, and we're very keen on developing mechanism-based therapies. We are very happy that we have a first proof of concept that Immuran and rituximab works for a manifestation in this disease. However, we want to get to a point where we can treat patients earlier, and also, if possible, with more selective agents. So when it comes to Candida, Candida is a commensal in the majority of us. So if we sample ourselves, 60, 70% of us or more will have Candida in our mouths, less often in the skin, the female genital tract. And it comes into 2 flavors. And although it's the same pathogen causing those 2 diseases, the host requirements for control of these 2 diseases are very, very different. So you need T cells of the IL-17 secreting program to defend against mucosal, and phagocytes to defend against systemic disease. So when we talk about phagocytes, let me just show you very quickly. Let me remove this laser pointer, otherwise I'm not going to be able to show you this video. So this is a live mouse. Red is Candida, gray is neutrophils. And what you'll see is Candida filamenting and then very, very aggressively attacked by neutrophils and destroyed in vivo. Neutrophils are important. We know that from patients who have neutropenia because of chemotherapy. This is a disease, systemic candidiasis, that really heavily relies on phagocyte responses. One of the syndromes that is monogenic and has a problem in neutrophils, both at the level of recruitment in the tissue, but also at the level of effector function, meaning killing, is carnine deficiency that causes infections in the CNS or in the skin. And why this is important is because now we have a lot of patients being treated with SYK inhibitors. Fostamatinib is now given in dozens of trials, including in COVID patients, to ameliorate inflammation. And these are the types of infections, unfortunately, you get. This is the third ventricle of a girl with Candida albicans. Actually, this girl, after, again, spending probably a year in the hospital, is now a teenager at the age of 18, doing quite well on secondary fluconazole prophylaxis. But this is the exception many times to the rule. This is another girl who came actually from Colombia, who developed this Coronispora infection. It's a cucumber fungus that in this particular setting can take hold in this disease. The patient spent a year in the hospital, had a bone marrow transplant, and unfortunately died from CMV pneumonitis afterwards. So this is the systemic correlates. However, let's talk a little bit about the mucosa, where T cells, not phagocytes, play a role. I would say lymphoid cells more generally, but here is the cardinal and seminal studies that came from in mice from Sarah Gaffen's group and in humans from Jean-Laurent Casanova and Anne Puel, that showed that if you lack IL-17 receptor, you're in trouble. If you're a mouse, you control the fungus in a wild-type setting, but not in a 17 knockout setting. There are now many cases of patients who have complete loss of this axis by receptor or adaptor, downstream adaptor deficiencies, that they get chronic mucocutaneous candidiasis. They also get sometimes skin staphylococcal disease and also pulmonary bacterial infections. And fast forward now, there are patients who receive actually IL-17 targeted biologics for psoriasis and IBD predominantly. And those target different kind of areas of the axis. There are antibodies targeting IL-17 or IL-17 AF and AF dimer or IL-17 receptor. So candidiasis has been reported to develop in those, not surprisingly. However, with a very small frequency. So for example, if you take the receptor blockers, frequency of candidiasis in the range of 3 to 5%, IL-17A blockers in the 1 to 2 to 3% range, indicating that perhaps these antibodies, the monoclonal antibodies used in the clinic, do not inhibit fully the pathway, and/or residual activity by other cytokines can protect against candidiasis. So a very robust axis, going from mice to rare monogenic disease to more common biologic-induced iatrogenic disease. So how is IL-17 thought to work? Through the production of antimicrobial peptides and the recruitment of neutrophils in the setting of infection. So here's a work from Sarah Gaffen showing in mice that if you're an IL-17 array knockout mouse, you do not induce key inflammatory molecules and antimicrobial peptides after infection. This is human work. This is the skin of a patient before and after starting an IL-17 blocker. This is not in the setting of candidiasis. This says that this is a molecule that also in humans is IL-17 dependent and can be dramatically decreased in the setting of an IL-17 blocker, but not fully gone. So, studies have shown at mRNA and protein level close to 85-90% inhibition, depending on the study. So this is a very, very robust axis that protects all of us from Candida. So you need a very deep decline in order to get in trouble. I mentioned those examples. And what's also important to note is that it's not only T cells that make those cytokines, it's gamma delta T cells and it's ILCs. And actually there is evidence in mice predominantly, but also early evidence in humans to indicate that all cells participate and they can actually compensate for each other in the absence of one another. So for example, if you have a mouse that lacks alpha beta or gamma delta T cells, they're not susceptible. But if you have a rag mouse that has deficiency in both, they get Candida problems. Patients actually with idiopathic CD4 lymphocytopenia very infrequently develop mucosal candidiasis, and a very small number of patients who have CD4 null mutations now had been reported to have other opportunistic infections, but not mucosal candidiasis, indicating that in the absence perhaps of CD4 T cells, gamma delta cells or ILCs can pick up the work and produce those important molecules. So we have focused our work on monogenic diseases that are not direct IL-17 receptor pathway deficiencies. We'll talk today about AIR, but these are three others that I'm listing here. In those diseases, CMC happens. It can happen as an exclusive infection problem or not necessarily. And in all of those, there is actually evidence, experimental data that have shown a level of impairment of IL-17 immune readouts in the periphery. So for these three diseases that I'm not going to elaborate further, there have been a percent of IL-17 producing CD4 T cells in the blood to be decreased. And for APECED patients, the two papers about 10 years ago showed, and we've confirmed that a majority of these patients carry autoantibodies against Th17 cytokines, predominantly against IL-17F and 22, and less so against IL-17A. So the majority of patients will have F, but not A, but about a third of patients could have both. So there were observations through the years that there were some patients who had these autoantibodies and did not have candidiasis, and vice versa, patients who had mucosal candidiasis but did not have autoantibodies, indicating that there could be other factors that might also contribute to the susceptibility, especially as we started seeing the frequencies that I mentioned earlier with monoclonal antibodies, where the frequency of candidiasis is actually quite low. So what that led us to do is to ask the question if the mucosal immunity of these settings are impaired. And the way we did it is twofold. One is we phenocopied these diseases in mice. So these are the 4 diseases that mice are susceptible. And then we've developed through the years, in collaboration with Niki Moutsopoulos, I think a world's expert in oral immunity, a human mucosal immunology program where we can take biopsies from the oral mucosa of patients and try to understand immune responses in humans at that specific immunological site. So our hypothesis all along had been that APECED patients develop candidiasis because they have problems in their local mucosa-specific immune responses. And in order to examine this hypothesis, we developed a mouse model of oral candidiasis in air knockout mice. Wild-type mice control the fungus, as is shown before. Air knockout mice are unable. This is specific for oral candidiasis. So if you actually take the same mice and you give them a systemic challenge with Candida, they're not more susceptible. They're actually even more resistant for reasons that we haven't explored yet. And they're not susceptible to systemic or mucosal viral infections, to skin staphylococcal, GI Citrobacter, or a ligature periodontitis model. The red highlighted ones are models that depend on IL-17 receptor signaling for host defense. If we look at the mucosa, what happens is at day 5 after infection, a wild-type mouse has controlled the fungus, and this is tongue papillae that look normal. And this is a lot of fungal invasion and proliferation in the air knockout setting, where you see invasion in the epithelium, no invasion deep, and an immune response that is there, but apparently not effective. So to our surprise, what we were able to show conclusively in mice and highly suggestive in humans was that air deficiency does not impair mucosal IL-17 related immunity. How did we reach to those conclusions? So first of all, mice are known to not intrinsically develop autoantibodies against cytokines, as I mentioned earlier. So in our hands, in those mice that we use, about 10% of them had autoantibodies against IL-17F. So candidiasis in these mice happens in spite of not having these autoantibodies. Transfer of air knockout serum in wild-type mice does not promote susceptibility to candidiasis. This is used through the years in, as I alluded earlier, in other autoimmune manifestations in the model, and similar results have been found that serum transfers in mice do not necessarily promote autoimmune tissue destruction. Then we took a comprehensive approach and looked at these entire axes from top to bottom. So production of these important molecules by all relevant oral mucosal lymphoid cells was intact. This is in mice throughout the course of infection, both for A, F, and 22. And in addition, in humans, in the oral mucosa by the relevant immune cell types. Downstream of IL-17, I mentioned that there are some antimicrobial peptides that have been shown to be 17 dependent in mice, in the oral mucosa, and in humans in the skin so far. And those were also intact. You can see here in the air knockout mouse throughout the infection, if anything, some were higher. and this is again the example of what you would expect in an IL-17 deficiency. In adult patients where we did biopsies, we found that these molecules were also present at similar levels. In the saliva, the levels of these cytokine antimicrobial peptides were also normal compared to healthy controls. Now, we took a further step and looked at RNA sequencing. On the left, it's oral epithelial cells from the wild type and knockout mice that looked at all known IL-17 regulated genes, and there was no difference. And then in patients as well, this is gingival mucosa. We've done this in the buccal in other patients as well, and the same data apply where in these adult patients we did biopsies, IL-17 regulated genes were not differentially regulated, indicating that in the mice and in those humans that we looked, IL-17 mucosal immunity appears intact, perhaps in humans, even in the presence of autoantibodies because of residual compensatory activity of some of the other cytokines of 17 that might not be fully neutralized by these autoantibodies at the time when we looked. So that led us to explore alternative mechanisms or cooperating mechanisms, if you will, of susceptibility. And we focused on the mouse where you can interrogate mechanisms. And what was very striking when we looked temporarily and throughout the course of infection at all immune cell types that would accumulate in the tongue before or after infection, CD4 and also CD8 T cells that I'm not showing you here for the interest of time were significantly increased. They were highly activated and CD5 high. This is what you see in every organ of air deficient mouse, whether it's an endocrine or non-endocrine tissue affected by autoimmunity. This is where the T cells look like this is uninfected mice, where you see this dramatic increase of CD4 and less of CD8 in the intraepithelial and submucosal layers of the oral mucosa. This is a patient on the right and a healthy donor on the left. This is, again, oral mucosa in the absence of infection, where you see this massive upregulation of CD4s in brown and CD8s in red. Again, this reminded us of what we see in every other tissue of mice and APECED patients that is affected by autoimmunity. And we wondered whether this excess of T cell accumulation might actually be contributing to the disease. And in order to do that, to show that, we took the approach that has been used in the past to show that T cells are actually necessary and sufficient to drive autoimmune tissue destruction in any other manifestation of APECED. What did we do? We make air TCR alpha double knockout mice. I showed you that earlier in the lung autoimmunity, where all of the autoimmunity was gone. Strikingly, the mice that lacked T cells, but they were air deficient, did not get mucosal candidiasis. In addition, we did adoptive transfers of air deficient T cells into mice that didn't have T cells. And that adoptive transfer of these T cells was sufficient to drive the disease, with contribution of both CD4s and CD8s in both of those settings. So this told us that in this mouse model, where T cells have been shown in the past to drive autoimmune destruction in every manifestation that we've seen, and in keeping with the fact that this is a thymic central immune tolerance defect, air deficiency, I mean, T cells appear to actually be the drivers of the Candida manifestation as well. And this is not really what we all think through for T cells, meaning T cells are thought to be important, and in most settings outside of air deficiency they are, but that also tells us that in certain settings, like in the setting of air deficiency, T cells can have the potential to be damaging. So that led to the question, what do these T cells do? And we took a very 30,000-foot view approach. We looked at the different cytokines that might be T cell bias. And what we found is a very striking enrichment of interferon gamma before and after infection. This is a CXCL9, this is an interferon gamma inducible chemokine. And no difference really in other cytokines. And a marked increase in CXCL9 in the saliva of patients, as you can see here. So the interferon gamma is coming from T cells, both CD4s and CD8s. These are oral mucosal in mice, as I'm showing here on the left, and in humans on the right. And that then told us that T cells that, as I showed you earlier, are really pathogenic, make a lot of interferon gamma, and they don't make a lot of other cytokines of other types of polarization. So we didn't know what that meant when we got that result, and we went to the literature, and there is extensive literature in the intestinal epithelial barrier that implicates interferon gamma, either alone or in combination with other cytokines, predominantly TNF, in actually damaging the intestinal barrier when it is in excess. So it's been implicated in inducing epithelial apoptosis, being anti-proliferative, and impair epithelial permeability by, at least in part, impairing tight junction production or scaffolding. So we went that route to see whether indeed in the epithelium we have evidence of this excess interferon gamma axis and epithelial disruption. So this shows phosphostat-1 signaling in primary epithelial cells from the mice with a significant induction of phosphostat-1 that is all driven by interferon gamma. Why? Because if you have an air gamma double knockout mouse, this is gone. So this is not type 1 or type 3 interferon related. There is a lot of interferon gamma R1 and 2 expression in the oral epithelial cells. I'm not showing you that. And in humans, you can see this phosphostat-1 signature in the epithelium, and this is a healthy control. So that told us that there is a lot of gamma in the mice and in the human mucosa, but it didn't tell us whether that's the predominant pathway. So for that, we went in an unbiased RNA sequencing approach, where in mice, first shown here, interferon gamma was by far the pathway that was upregulated. And you can see here both the summary and the volcano plots of representative genes. And again, in human oral mucosal tissue, where interferon gamma response was the top upregulated pathway, as shown here. That told us that it is not only that there is excess of interferon gamma, but that's actually the top pathway upregulated in mice and human oral mucosa. And as I alluded to earlier, this actually led to epithelial defects. So in mice where we can do these studies, we're able to show in situ with intravital microscopy that the oral epithelium was more likely to have dead epithelial cells in the air knockout setting and restored to normal in the air gamma double knockout setting. We also showed the proliferation defect I'm not showing you here for the interest of time. And then we devised a phytidextran-related assay that is used in the lower GI tract to look at permeability in the oral mucosa. And you can see this was an impaired response in the knockouts and restored in the double knockout mice. And again, corroborating prior literature in the lower intestinal tract, impair production of important tight junctions. So this said that in the setting of air deficiency, there is epithelial disruption, and this is driven by interferon gamma. That told us that this is a necessary pathway, but it didn't tell us that interferon gamma excess is sufficient to impair oral epithelial cells. So then we went to a human oral epithelial cells, and we exposed them to prolonged interferon gamma in a dose-dependent manner. You can see here, in a dose-dependent manner, you get epithelial death, even without Candida, and this is get worse in the presence of Candida. And in addition, using a permeability assay, an increase in permeability and a decline in clotting as a surrogate of tight junction. So now this told us that in the setting of oral epithelial cells, excess of interferon gamma can be sufficient to drive these defects. So we then went to air gamma double knockout mice and infected them, and corroborating the absence of epithelial disruption. And again, surprisingly to what do you think of a host defense not be driven by the absence of a key molecule, but rather by the excess of something else. These mice were able to control the fungus, as you see here, and we were able to show the same with two approaches that are FDA approved, such as interferon gamma monoclonal antibody and ruxolitinib. Then we went back to these adoptive transfers and asked the question, if gamma production is removed from these air knockout T cells, are these T cells now able to cause the infection or not? And the answer is no. So the first two I've shown you already, where adoptive transfer experiment of air knockout T cells is sufficient to cause mucosal candidiasis. But if you take the same cells, but remove their gamma production, they're not able to cause candidiasis. So the potential model here is that in the presence, in the setting of air deficiency, interferon gamma IL-17 is produced normally, as one would expect. And even in the presence of autoantibodies, predominantly to F, and in some settings to A and F, it would appear that in the patients we've seen, the axis is intact, presumably because of residual compensatory activity of type 17 cytokines. Again, this is in adults. We need to look at kids, and we need to look at longitudinally at more patients. The mice that don't have autoantibodies, it's conclusively shown that they don't have a defect in production of IL-17. What the mice have is a T-cell-driven, gamma-driven immunopathology that impairs the epithelium and allows for Candida to take place. In humans, we haven't yet conclusively shown that this drives the pathway. We need to do that with drugs that are targeting this, and this is underway. But we were able to corroborate the same findings in humans as we showed conclusively in mice. So then the conceptual framework to end of how mucosal fungal defense against Candida might occur is IL-17 deficiency likely drives the vast majority of mucosal candidiasis that is seen in humans. That's well known, and that's I think that's very well established. I think what we show here is proof of concept that in certain settings, excess inflammation rather than immune deficiency could either cause on its own or contribute to development of mucosal candidiasis. I think our data that I didn't show you here would suggest that both could actually be acting in concert. And I think it's exciting in the future to try to be able to dissect the mechanisms and see how those two might be acting in interplay or independent of each other. I'm going to end with our ongoing direction. So, obviously we're very interested in what actually activates these cells. It's not microbiota, I can tell you that. We have preliminary data to indicate that this is self-antigens, and we're very interested to identify those. Is this a thymic intrinsic or an extrinsic phenomenon? We think it's thymic intrinsic, but the thymic transplants are ongoing. What are the molecular mechanisms really that drive those responses? We've already working on this. Is excess interferon gamma sufficient to drive mucosal fungal susceptibility? We're working on this in mice that are transgenic for interferon gamma. Do these aberrant type 1 immune responses alter the Candida virulence? Do they make Candida more permissive to cause disease? That's something that we were in the plans of doing with RNA sequencing on Candida. It's tempting to speculate, and we have some preliminary data to implicate these axes as contributing in other primary immunodeficiencies that might manifest with Candida. I'm listing here 2 of them. And it's also very important, and we're in the process of doing this actually with a formal clinical trial that is about to start, but also off-label, to see whether JAK inhibition might protect patients from candidiasis and even more broad from autoimmunity. So what I showed you today is that expanded diagnostic criteria and increased awareness may have important implications in early recognition and improved patient outcomes of this devastating syndrome. Lung autoimmunity is a common devastating complication and response to lymphocyte-targeted immunomodulation. Understanding the pathogenesis of lung, and I would argue of other tissue autoimmune diseases in APECED, may have implications in other syndromes with or without known secondary AR deficiency, as biology is complex, but also there are common mechanisms that might be extrapolated from a rare disease to a more common disease in certain settings. IL-17 receptor-mediated antimicrobial peptide production is critical for protection during mucosal candidiasis, has been shown in mice and in humans conclusively. T cells are protective during mucosal candidiasis, but aberrant maladaptive T cell responses in certain settings can also promote or contribute to mucosal infection. And that appears to be done through excess interferon gamma STAT1 signaling, which appears to have direct damaging effects on the epithelial barrier to induce mucosal candidiasis. So to end, the way we think our research program, and again, we didn't talk about all of this, is through our basic work in mice. We're really interested in molecular mechanisms of what might drive fungal disease so that we can intervene and help. what drives these new iatrogenic risk factors so that preventive and therapeutic strategies can be implemented. And in the case of these devastating monogenic diseases, some of which we know already what the genetic etiology is, but also as we've enrolled over 500 patients the last few years of patients who don't have a known genetic disorder and they have different types of invasive fungal disease, and through exome and genome, we're interested in identifying new pathways to really develop novel mechanism-based therapies for fungal disease and autoimmunity, and ideally and hopefully help our patients. With that, I would like to thank the additional members that I didn't acknowledge as we were going through. And with that, I would like to thank you all for your attention. Again, thank you so much for inviting me, and I'll be delighted to take any questions.
Thank you very much, Doctor. We have many questions. It's fantastic, your presentation, your talk.
Thank you so much.
Yes, we are trying to read the question. One of them is, the first one is, why specific candida colonization if interferon gamma disrupt the barrier of the mucosal? Why do not see another microorganism?
Yeah, so I think that's a great question. So I think we don't have a conclusive answer for that yet. I can tell you what our working hypothesis and how we plan to address that is. So one possibility is that, and those might not be non-overlapping, but I'll list a couple of them for the interest of time. So one possibility is that that microenvironment is actually permissive for Candida to be more invasive. And I think a major axis of investigation would be to really see whether adhesion properties, invasive properties, virulence factors that are known to enable Candida to cause disease are actually modulated by this pathway. One other possibility that exists there is that some of these chemokines that are actually interferon gamma driven are known to have antibacterial properties, but not antifungal properties. So one possibility is that that excess pathway might actually, inadvertently, if you will, protect against certain pathogens, but not others. The Candida has a very unique feature, right? So in most of the patients that we see have Candida albicans. So filamentation is an invasive property of Candida. So Candida appears to participate in this, and other pathogens might not have those properties. And we've shown that with some avirulent strains of Candida where the phenotype is modulated. And the last thing I'm going to say is with regards to viral disease, where we've done some more work where the models are available in the oral mucosa, the excess of gamma likely helps control the viruses. So if you take the oral vaccinia infections we've done, actually, if you neutralize interferon gamma, that's when you get more viral load, and actually the knockout mice have less virus. So it is possible that, again, some of that axis might be permissive for fungi because interferon gamma is not necessarily a direct antimicrobial for Candida, but it could be for others, and/or Candida might be uniquely positioned to manipulate this. So, but we don't have a conclusive answer, and I think it's an important question. So we haven't yet conclusively addressed this.
Okay, thank you.
So thank you very much. Firstly, I like to acknowledge you for your eloquent and very clear speech encompassing diagnosis, treatment, and also pathophysiology. I'd like to ask you, did you try the lymphocyte-directed immunomodulatory regimen effective in APECED pneumonitis for interstitial lung disease in, for example, Sc.D gain-of-function patients?
So we have not tried that in Sc.D gain-of-function patients where, I'm not an expert, but I think, JAK inhibitors have been used with varying success. Now, the regimen we used, we did not discover by any means, right? So, you very well know about, CVID-associated interstitial lung disease with a lot of very solid work done by several groups that have shown that if you give Immuran and rituximab, actually you can help these patients. And although our patients' APECED pneumonitis doesn't have granulomatous component that much, we we were encouraged by that literature, and because some of the other features in the bronchiolar space are not very dissimilar. So we have, in a way, used prior experience adapted into this disease. We haven't yet used other models, and we haven't specifically looked at this regimen outside of what I told you with thymoma and our plan with idiopathic Sjogren's. And looking at the STAT1 and STAT3 gain of function, I'm not aware of colleagues here, Steve Holland, Gulbuzel, and others planning on that. But that could be something that could have an effect.
Thanks.
Okay.
Laura?
I have another question from Pilar Aoki. Pilar says, I have a philosophical question. What factors influence the triggering of clinical manifestations at different patient ages if the mutation is present from the born?
That is a great philosophical question, and I do not have a great philosophical answer for it. So I think it is actually very intriguing that most APECED patients, as opposed to, let's say, APECED patient, and let's go to another prototypic autoimmune disease with Treg deficiency, do not present the first 2-3 months of life with life-threatening autoimmunity. Whether this is because of environmental factors, whether this is function of air that is declining, or in certain cells, either in the thymus or extrathymic, is age dependent, and there is a crucial either stimulus or decline below a certain level that is important that triggers this. We do not really understand that. I don't think the field I'm in. It is true that there is dramatic variability in the phenotypic expression of the syndrome, even among siblings that have exactly the same mutation, and that's well recognized through the years. I think as immunologists that we see a lot of patients with primary immunodeficiencies, that's not really unique to APECED. I think we've come to realize that these are monogenic diseases, but they really have a dramatic variation, whether that's because of environmental factors and or other gene modifiers. I think we're still in the infancy of trying to understand those, but the question is very target on, and I don't know that we really understand that.
I have another question from Maria Soledad Caldirola. Firstly, congratulations again. You've showed enhanced STAT1 phosphorylation in oral mucosa. Have you tested STAT1 phosphorylation in whole blood monocytes? Same for STAT1 gain of function patients?
So in STAT1 gain of function patients, that has been shown before. So the patients with STAT1 gain of function, they have an increased phosphostat signaling and a prolonged phosphorylation of STAT1 after stimulation. In APECED patients, we have not looked in their blood. We are now looking in mice and in humans in their tissues, the non-oral mucosa tissues, like in their lungs. And we're generating this data right now. So we don't have a conclusive answer yet for that. That's a good question.
Okay, I have another question from Mariana Macione. If air controls autoantigen expression in the thymus, do you think that Th1 cells are recognizing tongue autoantigens?
Yeah, so without having conclusive evidence for that yet, we have a working our working hypothesis and preliminary data would indicate that that's really what drives the type 1 polarization in tissues. So we have looked in the periphery versus the tissues, and the gamma excess really is exacerbated in the tissue. And we have, again, preliminary evidence to indicate that there is self-reactivity in the oral mucosa. And through approaches that are combinatorial of single-cell TCR sequencing in human and oral and mouse oral mucosal T cells and other approaches, we're very, very keen to identify what the potential self-antigens might be. We do not know what that is yet. I think it would be important in general for the field, I think, of mucosal immunology and anti-candida immunity more particularly, but we do have evidence to indicate that there is self-reactivity in the oral mucosa, and what those T cells recognize is a very, very important direction of research. It's ongoing, and we don't know yet, but maybe in a year from now or 2 years, we will know.
Okay. I have another question. It seems like immunity in lung is, in spite of T cells are mediating the damage. In lung, you have a lot of neutrophils.
Mm-hmm.
And when you depleted T cells, you don't have more neutrophils. But in tongue, it doesn't seem that neutrophils are mediating the damage.
Correct.
What do you think about this difference, these tissue-specific differences?
So that's a great question. So first of all, I think as immunology always teaches us, and as we learn more about immune responses are always context and tissue and pathogen specific. So I think I would start by that as a general statement. So what are the cues in the airways to trigger neutrophil recruitment? We do not know those. We know the molecules, so we know the chemokines that are upregulated. We know that they're actually dependent on air deficient T cells, because if you have an air TCR alpha double knockout mouse, that mouse does not get neutrophils in the airways. In the mucosa, the neutrophil influx after candidiasis is actually driven by IL-17 receptor signaling. And again, in mice, that axis is normal. So the influx of cells was not greater in the setting of air deficiency. And even before Candida came in, and in humans as well, we don't see intraepithelial abscesses with neutrophils in the oral mucosa. This is very similar actually with the lung, right? So in the lung, you saw that all of the neutrophils were actually in the airways. And actually within the tissue, we don't really see neutrophil abscesses. Now, it is possible that some of that neutrophil recruitment is also magnified by the presence of bronchiectasis. So we do know from non-APECED related bronchiectatic lung disease patients that neutrophils are a major component of the airway leukocyte infiltrate. So I think that might provide some explanation, whether it's the accumulation of pathogens eventually there, the colonization, but we do not understand those cues in the airway yet.
Okay.
And we don't see neutrophilic abscesses in the air knockout tissues. And also, I must say now, we probably have looked at the tissue level, whether that's lung or salivary glands or liver or kidneys or stomachs or duodenum, over 80, 90 patients through the years with biopsies here, diagnostic biopsies, and neutrophilic infiltration in the tissues is not something that we see. It's in the airways specifically.
Okay, thank you.
Here another question from Paola Ferrero. Congratulations. What can you say about anti-type 1 interferons autoantibodies? Why patients don't have viral infections propensity?
So what do we know about the role of type 1 interferons? And I guess you have Dr. Casanova will elaborate more, but I can maybe give a little bit of a prelude. So genetic deficiencies of type 1 interferon signaling cause a certain group of viral infections. They don't cause indiscriminate susceptibility to viral disease. They cause important adverse reactions to MMR, to the vaccination of measles, mumps, rubella, to yellow fever, also HSV encephalitis. So it is true that those infections, MMR reactions or HSV encephalitis, have not been reported in APECED patients. Now, COVID comes, and outside of APECED, there has been now, I think, clear evidence that about 10 to 20% of patients with very severe COVID carry neutralizing autoantibodies to type 1 interferons. In a similar manner, in a paper that is under review actually now. Patients with APECED who do get COVID, a majority of them actually get severe disease, potentially implicating the autoantibodies as a driver of the hyper proliferation of the virus that then can lead to excess inflammation. So why they don't get MMR reactions and why don't they get HSV encephalitis? I think the more likely explanation is that there is still residual compensatory activity of some of the type 1 interferons. There are 17 of them. And although majority of patients have at least autoantibodies against 14 or 15 of them, again, whether there's complete abrogation of the entire axis or residual activity to protect, I think that's the more likely explanation why we don't see the more classic MMR or HSV encephalitis. Now, in the setting of COVID, this is a new virus. We don't quite understand this yet, but there appears to be a potential alignment. And whether this is a new virus that, when you exceed the level of proliferation, it can cause more inflammation. And that's why this is manifested as opposed to MMR and others. It is still a matter of questioning. But it is likely residual activity of some of the other type 1 interferons despite the autoantibodies.
Okay, well, thank you so much, Dr. Lionakis, for your excellent talk. We have a lot of great comments and congratulations to your talk. The audience has been very thankful. So, well, we have to finish this webinar now. And again, thank you. And we hope we can have you someday in person here in Argentina in some of our meetings.
Thank you so much. I really appreciate this. It was had a great time, and I hope we meet at some point safely soon in the future. So have a good night.
Very much.
Right.
Thank you.
Thank you so much. Thank you, Laura and Silvia. Bye-bye.
Thanks.
Thank you. Bye-bye.
We'll be in touch.
Yes, yes.
Take
Thank
care.
you, Michail.
Thank you again. Thank you. I appreciate it.
Fantastic, fantastic talk.
Bye.
Bye-bye.